Hello, good afternoon. My name's Wilson Szeto. It is a pleasure to be here with you this afternoon. We're currently at the AATS annual meeting in Boston in 2022. It's a pleasure to be here with Dr. Michael Moon from Canada. We're going to be spending the next few minutes talking about this exciting new technology, the AMDS device, the experience in Canada, as well as a trial that is ongoing here in the United States, the PERSEVERE trial. So lots of exciting stuff to talk about. And finally, love to talk to Dr. Moon about the late-breaking clinical trial and the 3-year outcomes of the DARTS study. And I'm really looking forward to that. Dr. Moon?
Thank you for the introduction, Wilson. My name is Mike Moon. I'm at the University of Alberta, and I've had the opportunity to do the first implant back in March 2017 in the DARTS trial. Over the last 5 years, we've had a great experience with the device and learned a lot about aortic dissection.
Just to let you know, Dr. Moon, from my perspective, my involvement with AMDS has been interesting. It was one of those interesting stories. It was literally a cocktail napkin at a restaurant many, many years ago with the founder and designer. And that's how I've been involved early on. And from that beginning, that moment, I felt that this technology was going to have a major, major impact in the treatment of patients with DeBakey-1 acute type A dissections. I would love to get your sort of overall perspective of your experience over the last few years, because you are a world expert. You have the highest amount of experience and volume with this. What are your general thoughts about how this is going to impact our field? And more importantly, how is it going to improve the care of our patients?
Thank you. The very first time I thought, or I heard about the AMDS, I got an email from Ali Shariari, and he had this novel concept of the AMDS stent, and it was something that always in the back of my own mind I'd actually been thinking about, like we have to do something different about the aortic arch. How can we improve how the aortic arch looks after our standard hemiarch replacement? And it was something that seemed so natural or so obvious a solution. And he presented this device that he had come up with, what his thoughts are, how it actually helped the patient. And he said, well, do you want to actually get involved with the study, try and implant this? And I remember asking him, like, has this ever actually been implanted in a person? He's like, no. And I was like, okay, this is going to be quite interesting. So you want me to try and put this into a human being for the very first time? And I said, well, okay, well, it makes a lot of sense. What I did like about the device is it seemed intuitively it should work. It should allow us to address the aortic arch. I thought that it would definitely try and eliminate or address how the false lumen looks. And it was something that over the last 5 years, I've been very happy with how the device performs for our patients. And some of the things that we have seen is, in addition to remodeling of the aortic arch, the ability to treat malperfusion is something that I think is absolutely amazing. And we have seen in our practice, patients with significant clinical malperfusion have complete resolution and have had excellent outcomes. And I think that's something that we've not seen before this device in our hands.
So Dr. Moon, please tell us about the device, how you implanted, what the overall concept of this device in terms of aortic remodeling of the arch.
Yeah. It's a hybrid device that is meant to be deployed in an antegrade fashion during circulatory arrest through the open anastomosis. The proximal component of the device is a felt strip, and the distal component's an open cell bare metal nitinol stent. The felt allows you to create your distal anastomosis, which is going to be reinforced, and its goal is to decrease the incidence of a DANE, a distal anastomotic new entry tear. I think that's an incredibly important part of the stent. The open cell technology of the stent allows you to have ongoing perfusion antegrade across the aortic arch. So the open cells do sit across the aortic arch, and if required, you would still be able to access the head vessels from the groin if any patient did require a secondary intervention. It allows the true lumen to expand, and hopefully by having the felt cuff decrease the incidence of Verdane, with the true lumen expansion, the goal would be to promote remodeling in the aortic arch and the proximal descending thoracic aorta, and also address malperfusion with the true lumen being stented open. The device is meant to be an adjunct to the hemiarch procedure. So from a surgical perspective, one of the unique things is this is a device that does not force a surgeon to change how they will address a patient with a type A dissection. So standard hemiarch, open distal anastomosis. During circ arrest, you deploy the device antegrade, and you still do your hemiarch anastomosis. The only difference would be that this would be reinforcing your distal anastomosis.
That's excellent. So this allows a surgeon to be able to do an operation that he or she is comfortable with.
Yeah.
And if it is a hemiarch, this will allow you to have a strategy to treat the distal aorta. Now, any concerns in the arch or any factors in the arch that you think this device may not be a good idea to use?
Yeah, excellent question. In people that have the primary entry tear in the aortic arch or people with aneurysmal aortic arches, the most appropriate procedure at that point would be either a frozen elephant trunk or total aortic arch replacement. But in the absence of that, this is, I believe, the most appropriate adjunct to the hemiarch, which in most cases is still the gold standard.
Agreed. Now, you're one of the world's leaders in terms of experience, in terms of not only implant volume, but also how long you've been doing this. Your group taught us a lot over the last few years. In your one-year publication of your outcomes, the DARTS trial, demonstrated very encouraging results. Can you further expand or comment on the results and the observations you found with your early experience in that one-year outcome manuscript?
Yeah. What we saw in the one-year data was that we had two main observations. Number one, we were seeing that the false lumen was being addressed. So the false lumen is decreasing in size or obliterated at the one-year mark in most of our patients. The second thing that we saw in a subsequent publication was that we were addressing malperfusion in over 95% of the cases. So in the patients that did have radiographic or clinical malperfusion, that we were able to address that completely. So on follow-up studies or clinically, the patients that did have issues with malperfusion, it was addressed. So the device was allowing us to help our patients by both positive remodeling in the aortic arch and the proximal descending thoracic aorta, as well as addressing malperfusion, which, as we know, is one of the leading causes of death in our patients postoperatively.
I was also encouraged to find in that publication, granted, taking into context that this was done at centers of excellence, so we have to take that data into that proper context, that the malperfusion group actually had a very, very encouraging outcome compared to some of the historical studies and series. Any thoughts about the impact of this device in terms of treating that patient group population and also 30-day mortality?
Yeah, so what we saw was patients that we expected to survive surgery but have potential serious issues postoperatively, that was something that we were no longer observing. So, when you look at a preoperative scan and people are having SMA occlusion, celiac occlusion, and you're concerned in the postoperative period, this may be someone that needs a laparotomy. That was not something that we observed. And early imaging, whether it was within the first 24 hours, 48 hours, when we looked at their studies, we saw that they had normal visceral perfusion. Mm-hmm. And it matched what we saw clinically for our patients. They weren't coming out of the operating room with lactic acidosis. They weren't coming out with severe pH issues. So that was something that we saw. Anecdotally, we had 3 patients that actually presented with evidence of spinal cord ischemia. We had 3 patients that presented with paralysis. But those 3 patients specifically had complete recovery of their spinal cord issues. I don't tell patients that they're going to have resolution of spinal cord issues. I say that, I preface it by saying, this will not recover. But my colleagues in London and Montreal, they had these patients where they were not expecting it, but it was able to address that. And it's, I think, a device that was not set out in my mind to be a malperfusion device, but I think one of the biggest benefits for our patients is the ability to address malperfusion.
Excellent. Now let's transition a little bit about aortic remodeling. Less of an acute perioperative topic of discussion such as malperfusion, but more about distal aortic events, reintervention, and distal aortic remodeling. Mm-hmm. Your 1-year outcome in the DARTS study also shed some light about the potential impact on this device on aortic remodeling. My recollection was that aortic remodeling was very positive and favorable, especially in the arch and proximal distal aorta. Mm-hmm. That effect may wane as you go more distal, but can you comment more about specifically what you found in that study in terms of aortic remodeling?
Yeah. So when I first thought of this device, it made sense to me because it is following what we have learned about type B dissection with a covered stent graft proximally and a bare stent distally, if that is how you manage your...
Correct, the stabilized concept.
Exactly, the stabilized concept. So if you believe in that, which is how in my own practice I treat my type B dissections, this was just moving that same concept proximally. So the ascending aortic replacement, the hemiarch procedure would be the equivalent of a covered stent graft, and now we're putting a bare metal stent across the aortic arch. So conceptually, in the absence of significant communications between the true and false lumen of the head vessels, I would think that we would have a similar observation. And that is what we saw. We saw that the more proximal you were, meaning the aortic arch, we saw positive remodeling. We saw that the true lumen is expanding, the false lumen is decreasing. In many of the patients, the false lumen was disappearing. It was either completely thrombosed or it was absent, meaning all we saw was true lumen. The proximal descending thoracic aorta also was being close to the ascending aorta. The more proximal you were in the descending thoracic aorta is where we saw more remodeling. As you get distal into the mid-descending thoracic, the distal descending thoracic aorta, you see less remodeling, but that makes sense, and that mirrors what we see in the type B population. So, if patients have significant or multiple communications between the true and false lumen at the visceral level, that part of the aorta you would not expect to completely heal or remodel. And I think that's an important thing when I talk to my colleagues about the device. In terms of their expectations, I tell them, like, if you have 3 of your visceral vessels that are going to be communicating with the true and false lumen, you will not expect the distal thoracic aorta to have complete remodeling. But in my mind, the biggest benefit to this device was being able to move the disease distal. And as you know, many of our patients with type A disease, they still have, if there's a false lumen issue and you have a DANE present, we're needing to do a total arch replacement. We're needing to do proximal descending thoracic work, all with circulatory arrest. And if, as surgeons, we could move the disease process distally, either giving us a place where we could either land a stent graft or have a place to clamp in the left chest, it would change the morbidity of the procedure for the patient and would potentially change the type of procedure that would be required as a secondary interventions.
So I want to congratulate you for the late-breaking clinical trial abstract that was presented by your group here at our annual meeting at AATS. That's the DARTS 3-year data, building on your early experience. Can you share with us the findings and the observations of your 3-year follow-up, trends, lessons learned, and what future implications that you may have based on that data set?
Yeah. remodeling is not something that happens immediately. There will be patients on their first postoperative scan that you see a dramatic response where the false lumen is completely absent. But other patients will take many years to remodel. So that is one thing that we saw. The other thing that we saw was in patients that did have the false lumen still present, meaning that they had not completely thrombosed or obliterated their false lumen, that those patients demonstrated stability. And that's an important thing because we all see patients where they have early growth. And we didn't see patients that, we didn't have any patients that showed up within the last 5 years needing a redo total arch. Whereas in patients where prior to AMDS or patients that had just a hemiarch, even within our own practice, there have been patients that have had to come within that time period for a redo arch replacement as a result of ongoing flow and pressurization of the false lumen. And I think that when we talk to our colleagues in the country, that is something that we see in the absence of the use of the AMDS. So it definitely pathophysiologically makes sense that if you don't eliminate that flow, you don't eliminate that pressurization, that it will drive the growth of the false lumen. And that's something that we saw. So with the 3-year data from the DARTS trial, that we saw ongoing positive remodeling, and we also saw that there was stability within the aortic arch, both which were incredibly important. We didn't see any change in terms of malperfusion because that was all addressed immediately.
Early. Well, Dr. Moon, that's been very valuable and insightful, and I thank you for sharing your experience and lessons learned. What I'm hearing is the following. Correct me if I'm wrong. What I'm hearing is, number one, this is a device that allows surgeons to stay in their comfort zone and do an operation that most of us are comfortable with, a hemiarch, for a repair of DeBakey 1. That's number one. Point two, I'm hearing from you and the data that it is potentially impactful in treating a very subset sick group of patients with the DeBakey 1. And these are patients with distal malperfusion. And I think point three, which has gotten a lot of investigation over the last decade, is aortic remodeling. And it appears to me that is extremely effective, at least in the short term, short to intermediate, up to 3 years, very effective remodeling in the aortic arch. And I think those are 3 takeaways that I have received just from talking to you today. Would you echo that?
Yeah, to your first point, in our group we have 7 surgeons, and they, as they have more experience with the device, it's something that they all say, wow, it's actually not that hard to implant. Every surgeon has a huge amount of anxiety or concern about trying to implant something new the very first time they have to do it, especially in the setting of an emergency procedure, an acute type A dissection in the middle of the night. How are they gonna feel about implanting something that they've never done? Every single time we help them or they implant it, they always say the same thing. Oh, that's it? That's all we have to do? And I'm like, yeah, that's the device. So from the perspective of surgeon comfort, it's a very, very user-friendly device. It's a device that only adds a few minutes to the procedure. And I think the most important point is it doesn't force the surgeon to deviate from what they want.
I think you're absolutely right. And I think, as I think about this device, first and foremost, I think based on the data I've seen, it saves patients. It helps patients. Number two, I think it also helps our specialty, meaning it's a tool, a new tool in the toolbox for surgeons to do a better operation at the time of an index operation for a DeBakey 1. I think that's what's so elegant about this new technology. This is really, in my opinion, impactful new technology that's a win-win. On the backs of your leadership and your knowledge, I'm excited that finally in the United States, we're always behind our Canadian, European colleagues. Finally in the United States, we're gonna have access to this device The trial is called PERSEVERE. You're familiar with this. I've gotten your expertise and help in terms of training and design. The PERSEVERE trial is a US IDE study that will include 20 to 25 centers with roughly close to 100 patients enrolled. It is going to be focused with an inclusion on DeBakey 1 patients with malperfusion, whether it's clinical or radiographic. And we're very, very excited that we are able to start very shortly in the United States.
What I do like about how cardiac surgeons are managing aortic dissection, it's on the coattails of what vascular surgeons have been doing for many years already. And I think that the benefit that they have been able to see in their patients at type B dissections is something that we can learn from and also hopefully bring to our type A aortic surgery patients. But I think it's going to be a very exciting study. I think that because you are including the malperfusion, you're going to see a very striking difference in the outcomes of patients that historically have been plagued with serious issues even after a hemiarch replacement.
Where do you think this field is moving? And where do you think this AMDS device will fit into the entire toolbox of a surgeon, and how that would impact perhaps maybe shifting that paradigm back a little bit in terms of aggressiveness of how we manage the arch? Where do you think that sweet spot's going to be in terms of when do you do a total arch? When do you do a zone 2? When do you do a hemi-arch with an AMDS device? Where do you think the future is in terms of the management of the arch in DeBakey 1s?
If you were to ask me how many total arches I do in dissections, 10 years ago, I was doing a lot more total arches. I was very aggressive with aortic arch, especially in the younger patient population. I didn't want them coming back. I knew why they're coming back. They're coming back for false lumens that are growing in the arch. They're coming back needing circ arrest for left chest work. Over the last 5 years, seeing how the aorta remodels, I've actually been doing less total arches because I am seeing in these patients that the arches are no longer going to be the reason that a patient has to come back. And seeing the, time after time where the CTs are showing that the false lumen of the arch is absent, it's obliterated, I've actually shifted sort of my philosophy that, I don't have to be so aggressive at the index case. I can do a hemi-arch, put an AMDS in, and get the same result where malperfusion is going to be addressed, the arch is going to be healed. For me, I've actually stepped back, and it's not because I can't. It's just that I am seeing, I'm making observations that I didn't see before. So for me, I've actually taken a step back. Hemi-arch with AMDS is what I think most of the patients will actually be able to get the results that they want.
As I think about doing total arches, zone 2 arch or advanced arch, complex arch, however you want to label it, even in the world's best expert hands, it is a complex procedure. I think all of us would agree with that. And I think if you have a solution, i.e. a new technology, that allows you to be able to treat a disease process as effectively without the more complex procedure, I think that's a win-win for the patient as well as for the surgeon and the surgical team. Recently published manuscript looking at the STS adult cardiac surgery database, the median number of dissections, type A dissections were done per center, not per surgeon, per center was 2 a year. We have a duty when we see these patients that we provide these patients with good care without delay and acceptable outcomes. And I think this is an extremely impactful technology that will allow us to do that. So I just want to wrap up by saying thank you, Dr. Moon, for being here today. Thank you for sharing your knowledge, your expertise. And again, congratulations on your late-breaking clinical trial abstract. I look forward to reading the manuscript. Thank you very much.
Thank you.